as we're taking care of all patients, this is not just really the LGBTQ population, but really everyone, we're going to develop that comfort and trust. And this is really with all of our patients. This is what we're trying to achieve, I think, in general, to develop that comfort and trust. What we find, though, is that the terminology is sometimes so far ahead of us that we can't keep up, and then we find that there's a mismatch. You know, the physician, the staffing, and then the patient. I have 4 kids, and I find that even with my kids, my terminology that I understand and what they do is a massive mismatch. They're going to be much more comfortable with a lot of the words, terminology, behaviors than I think that anyone that's really come out of the last generations could be, because they're hearing it in a different way than maybe we all did, again, and even in their schooling education right now. So my goals today are really going to be these 3, just understanding some definitions. I'm going to go over very common definitions, but I'm also going to talk to you about some things that maybe you're not so familiar with. Talk about some unique barriers that are really preventing great care in the LGBTQ plus population, and then talk about some strategies to try to help out with improved outcome, specifically trust and then also satisfaction from our patients. So why does this matter? And I think this is a good starting slide, which is if you look at the population at large, there are 2 different pie charts here. On my closer side, the blue Pac-Man over here, that's 90% is approximately what the male sexual orientation is. And we'll talk about what sexual orientation is in a moment. Declares as heterosexual. And then on the green, 2.3% homosexual, bisexual 1.8%, and then there's many that don't declare. And if you think about that, you know, this is a pretty good amount of our patient panel that really will come in to see you as a provider that are declaring themselves either as undeclared, bisexual, or homosexual. And then again, you can see similarities on the female sexual orientation side as well. So one of the reasons why it matters is because, you know, this is our population that we're really serving. So we're going to start out with some basic terms. Some of these, again, you know, and some of these maybe get a little bit challenging because the words mismatch and it's hard to understand it. But the parent piece that we talk about is sexual identity, okay? So this is understanding the biopsychosocial aspects of the various variables of how one identifies themselves. This is not something that has to be fixed. I'm going to talk a lot about these dimmer switch moments where it's not all or none. We'll talk about Kinsey, Alfred Kinsey in a little bit, but this can evolve over the course of your lifespan. And there are 3 interlocking pieces we'll speak about. So sexual orientation, gender identity, and gender role. I'll define each of those so you have a better understanding about how each one works. So the first one is sexual orientation. I just brought that up in that first slide with the data. This is one's emotional and physical attraction towards men, women, or both. And there's really no conclusive biological, psychosocial findings regarding the why behind this. This could be thought, though, as an intrinsic personality characteristic, and specifically, this is something that may emerge in the early adolescence. Very important, too, for those who take care of adolescent patients, and why we want to start at that adolescent age to start to ask about sexual history, and ask because this is typically where there might be some expression as well, sometimes even prior to that in the pediatric population. So it's not determined by sexual acts, okay, very important, but by one's erotic attraction, okay, and that's also something to really think about there too. They may identify as gay, lesbian, or bisexual, but not having any same-sex activity. And that people may engage in sexual activity that's not consistent with their sexual orientation. And this is where I think people can get confused as to how to understand this. But that third point is very, very key for care within the healthcare realm. And that sexual preference is not appropriate because that implies that it's a sexual orientation is a behavioral choice, which it may not necessarily be, where it's not. So I mentioned Alfred Kinsey. Alfred Kinsey is a very well-known sexologist, and he put together a scale I'll speak about, but he had quoted that, this is one of his famous quotes, "Nature rarely deals with discrete categories. The living world is a continuum in each and every one of its aspects." And if you think about this from what I'll say, the mahogany versus cherry wood, Kinsey put this into 7 different types of dimmer switch scales. It's not all or none. He actually had a very prominent way he put it. It's not people are not goats or sheep. Okay, it's not one or the other. That they may be somewhere along this kind of dimmer switch into where they fall on this scale for heterosexual and homosexual. And I think that's very important, because if you're looking for something exact, I think that that's probably the wrong way to think about it. And again, Kinsey put this together many, many decades back. So some of these, again, you'll see these, you'll understand them. I'm going to go through them relatively quickly. But heterosexuality is the emotional and physical attraction to the opposite sex. They may self-identify as straight, but be mindful that some may find that term derogatory. So, and again, terms you'll see, we'll talk about these kind of come in and out of phase over time. And we'll talk about one actually right here that has been in and out of phase multiple times. Homosexuality, men who have primary emotional and physical attraction to other men. And this is one of those terms that you probably have seen. Queer decades ago was seen as derogatory, but now it seems to be more kind of in kind of the vogue again. So I think you're going to see these words and terms potentially blend in and out, but understand that I think it's important to kind of get these words as sometimes how people will refer to themselves. As well, women who have emotional and physical attraction to other women, and they may self-identify as lesbian, gay, or queer as well. Very important, if we think about healthcare settings, 70% of gay men and 80% of gay women have disclosed to their primaries that they are gay. 70% of gay men, 80% of gay women. Bisexual, 24% have disclosed it. So we're talking about almost a 55% change on average between these different groups. So this is an area that we have to really focus in on. As you can see here, bisexual women and men who have physical and emotional attraction to both genders, and they're frequently spurned. So because of that, they tend to not disclose their status in healthcare provider offices. And sometimes we'll talk about some of the reasons why the provider themselves may not feel comfortable even bringing this topic up. So some of the myths that really come about with this is that they're confused with their identity, or they're stuck in a coming out process, or they're afraid to be due to stigma, lesbian or gay. And or that they're hypersexualized. And I think that these obviously kind of allude to potentially only having such a low 24% understanding from that healthcare setting of disclosure. So we're going to talk, before we get into the gender identity and the gender roles definitions, we're going to talk about this model that came about by Vivian Cass back in the 1970s. Vivian Cass was a very well-known psychologist who talked a little bit about the identity modeling of LGBT patients, what they may go through. Thinking about it similarly to Kubler-Ross, you don't have to go through all the stages in Kubler-Ross. People may skip from denial to anger, or not really hit any stages. They may not hit all stages, and separately, because of their background, their socio-cultural background, they may have a whole different experience. So this model doesn't necessarily hold up in all contexts, but it's important to at least think about it from some perspective. So the first thing we're going to look at is we'll talk about each of these from the bottom of the staircase to the top. Identity confusion is going to be first. So what is identity confusion? It's first awareness of the patient of same-sex thoughts, feelings, and attractions. And that the patient feels, or the person feels, different than one's peers. Each of these segments, I'll ask the questions that the patients are probably feeling themselves. Okay, so usually the second or third bullet, you're going to be seeing the questions the patient may be asking for that stage. So they're going to be asking you, who am I? Could I be gay is potentially that first stage. And as you can understand, this is going to create confusion and turmoil, and that may lead to the initial parts of withdrawal from, could be classroom settings or workplace settings or other settings that they're involved. Next is identity comparison. This is going to be a heightened sense of not belonging or feeling that they're in some type of different setting than their peers. So if you think about it again with these different scales like Kubler-Ross, there's a bargaining stage effectively. Think about that. This is kind of where that's coming up as well. And maybe this is just temporary. That's the question that they ask. It's a one-time deal. They may be asking themselves as well. They have feelings of self-alienation, and this is where they start to go from withdrawal to possibly even further isolation. Identity tolerance, this is another stage that might occur, acknowledging that he or she is likely gay, but is tolerant rather than acceptant. They're not belonging with heterosexuals, is becoming stronger. They may seek out other gay and lesbian people to combat feelings of isolation. Acceptance, they're going to accept rather than tolerate at this point their sexual identity. They may start to have attached feelings, I'll be okay, as they are in this stage. The who am I and where do I belong may be answered for that person, because now they've had more time to understand where they are with this. And they're going to potentially have increased contact with gay and lesbian culture as well. Identity pride, a person who's immersed in gay and lesbian culture, I've got to let people know who I am. They may disclose, and this is where coming out with a sexual identity may occur. And they may divide the world into hetero and homosexual, us and them, and they may minimize contact with heterosexuals. They may have anger at heterosexuals and devalue many of their institutions. And lastly is identity synthesis. So integrate sexual orientation with all other aspects of self rather than sexual orientation being their entire identity. Retaining a deep sense of pride, but less of hetero-homosexual dichotomy, and recognition that many heterosexuals may be supportive and trusting. And again, I can't stress this enough. This does not mean that everybody goes through these stages. This is just a model, and based off the patient, this might be something where they skip multiple stages, they skip all stages, but it's just something to think about because this is something that can progress as they start from some of the initial withdrawal phases. And this is something we'll talk about in a little bit for the healthcare setting, what we need to really pick up, that withdrawal phase in that patient and how that can actually affect their healthcare. Coming out, we've heard this term before, and again, this is that decision to voluntarily reveal sexual identity. And this could be involved in telling family, close friends, close members of their circle, or it could be more widespread, and I think within this world of social media, we may see it, even more widespread with the various forms that people may use. And they may not come out because of risks of meeting prejudice or discrimination, which we will speak about as well. So I did mention that with sexual identity, there's a few different parts. There's sexual orientation, then there's gender identity. So gender identity is a sense of acceptance and belonging to one's gender. And this is our perception of maleness or femaleness. And it separates psychological factors from gender from biological and societal factors of gender. Now this can develop as early as age 18 months to 2 years of age. So, for those who take care of children, this is something that really may start to actually show itself as far as identity in that very early phase. And again, I mentioned that there's a third part here too, which is gender role. These are the perceived cultural norms, and I think these pictures possibly sum it up, where you've got the woman that's in the military fatigue uniform, and I think that perception may initially be, well, that would be a male. Person behind her is in a ballet pose, ballet type uniform. Perception may initially be that would be a female. And I think that that's where these roles, perceived cultural norms develop stereotypes. And I think that, where we have to at least be aware is that everything is evolving in culture. So they're dynamic. Just like what I brought up with Kinsey's scale, there's dynamic aspects. And I think that if we get something out of this, I think if we go away from binary and go towards dynamic, we're probably going to do better with healthcare. Obviously, very, very contemporary topic that we're hearing quite a bit about. If we think about the lesbian, gay, older male, older female, in the 1970s, they lived through raids of bars, police raids of bars. And the 1980s was the HIV, significant HIV media outburst that they lived through. And then eventually it was the marriage equality that started to come about in the 2003, 2004 zone, all the way out through the early 2015, 2014 zone. So the older male, older female who's LGBT, the lesbian and gay, older male, female, they really have been through a lot of what now I think the transgender population is really starting to kind of go through as well as we speak. So people whose gender identity or expression differs from that associated with their birth sex, they may identify, desire to be with, dress as, or transition towards the opposite sex. Very important, these key words, and I want to make sure that you know that these are very different. Their difference is we want to make sure that we understand that drag queens, cross-dressers, and transvestites, these are people that may, as an example for cross-dresser, could be a male that's dressing in women's clothing. Okay, that is not transgender. We want to make sure we understand that that is not. Transvestite dresses in women's clothing. A male dressing in women's clothing could be for entertainment purposes. Now, transsexuals, I bring that up too because that's a transgender person who now has had an operation for some various types of surgeries that have actually started to actually affirm their change towards another gender. So that is a different terminology as well. It's important to kind of go through each of these and understand they're very different. And I think that's something that, again, with terminology, I hear people get confused quite a bit. So this is where things get probably even more confusing for all of us. So identity versus orientation versus role. So although related, gender identity and expression and sexual orientation are mutually exclusive. And I give this example of a post-op transsexual female to male who identifies as gay and only dates gay men. So this is where it's important to really understand that each of these really should be discussed and understood, so that way you can at least help the patient out with the variety of questions that may come up. And again, I'm going to even now include another factor here too. A man dresses as a woman, but is sexually, emotionally, and exclusively attracted to women. So you can understand sexual identity can be expressed in a number of ways. And I think that it's good to continue to think about the dynamic, not binary aspects of really any of these definitions that we really think about. So how do we now start to kind of think about this in our practice? So first is we have to understand the terms. So I think that you at least have a basic understanding of the terms right now. And then when you're in these different settings, it's important to start to understand your own belief systems, your own attitudes, and your own understanding. So that way you can at least understand how to provide care and make sure that they don't impact the healthcare setting. The goal is to remove your own beliefs from the healthcare setting so they don't impact care and potentially create prejudice and discrimination. And we'll talk about a couple that are very, very common. One is homophobia, which is meaning fear of the same, and this is extreme irrational aversion to lesbian, gay, bisexual, transgender people. And this can be open or covert, and this does happen in healthcare. There's a lot of data out there that shows that it exists. Very common, and I can give you an example of you have two patients that come in. And they're both women who now are in the same room. And if one of them is asked, who is this? Is this your sister or mother? If now it was a male and female, there may be an assumption that that's the relationship versus that's the family member. And I think that this is important because, you know, this heterosexism is a bias in favor of heterosexuality. That's almost, you're assuming that the patient in front of you who's a woman has a husband. And I think that happens a lot. If you have a couple who's pregnant, a lesbian couple who's pregnant, and the question comes up, there was a really interesting survey that came out years ago where the patients were asked who's the mom on a regular basis. That's effectively the same type of thing on a heterosexism level that happens. And again, that third thing here, it may not be intentional. So this is what I call the ketchup on your shirt moment. You don't know that it's there. Somebody's got to tell you that it's there sometimes. Sometimes it's a staff member or colleague, but you don't know. So sometimes it's not intentional, and sometimes it is intentional. And I think these things, you know, are where you have to think through how you style what you're asking. Also think through, and we'll talk about your intake forms as well within the office, how we could try to decrease this. So plenty of research that shows that heterosexism and homophobia exists within healthcare. And because of that, we may not understand the pathology or physiology of what's happening with patients. And we'll talk about some of the risk factors in a moment. That then will lead to refusal from the patient to even talk about this topic, which then decreases what we're trying to do, which is provide trust and comfort and really try to do health promotion, disease prevention. So it's this cascade where it just leads that direction, and we have to really be careful because then we're going to be at risk of what we're going to talk about next, which is a lot of the health risks of the population. So you'll see these acronyms: women who have sex with men, men who have sex with men, that will be in the next groupings, and that there are disproportionate experiences between the populations that you'll see that are risk factors. So let's start with women who have sex with women. There's very, very good evidence that each of these boxes are things that we have to really be thinking about and screening for. Decreased exercise, nutrition, increased obesity, three times the risk in this population. Increased tobacco use, alcohol use, drug use. We talked about withdrawal. We talked about isolation. Increased depression and anxiety, decreased gynecological care and screenings, less children, null parity, and decreased screening for domestic violence. These are very, very important questions. And again, social history and sexual history are really where these come up. So we can miss very, very big things that cause health disparity and cause chronic care issues. That will come up if we don't ask these questions, if they're not comfortable answering the questions. Obviously, all the STD aspects, and thinking about this, you know, this is another one of those areas where how would you even really think about this if you don't start to ask questions? We always say there are three questions you want to start with for the sexual history. We want to ask if the patient's sexually active. We want to ask if they have sex with men, women, or both. And even just to challenge this a bit, you know, that in itself is not necessarily helping us because of the terminology with some of the non-binary aspects of where we are, which we'll speak about. But the second one, again, is do you have sex with men, women, or both? And the third is how many partners, sexual partners they've had in the last 12 months. Those three questions kind of open up the box a little bit in this discussion. They should be asked for all of your patients. I got to give credit when you see students throughout the convention today, they're asking these questions every single time in our healthcare visits. That will help us with not just this, but many other preventive medications we might even decide to use. Health risk factors for men who have sex with men: increased tobacco use, drug use, alcohol use, similar, same, depression, anxiety, decreased screening for domestic violence, safe sex practices, decreased hepatitis screening, and then even body image problems and eating disorders. Keep that one in mind too. There's a lot of eating disorders both from the obesity side as well as bulimia and anorexia that can happen. And we really have to make sure that we're picking these things up. If we wait for things to happen for that end stage where the BMI is too low or the BMI is too high, maybe we can try to help people out before this even happens at the adolescent phase, at the pediatric phase, even younger. So, and again, I even throw in here one thing that we're really seeing quite a bit of, pre-exposure prophylaxis, if you think about it. And if you haven't seen this, I'd recommend going to it. The CDC has a very, very good chart on when you would think about using PrEP for patients. So if they have a background of having a man who has sex with men who has had exposure to chlamydia or gonorrhea or syphilis, there are very good indications as to when to use PrEP, yes or no. If they have had exposure to somebody that they don't know the patient's status for HIV, when to use PrEP. And I'm not really going to, PrEP is a whole separate lecture in itself, but it's important to really think about this from the transmission prevention aspect. So what else can we do? Again, evaluate your beliefs. So, if you have personal religious and or moral beliefs, you want to separate those from healthcare visits to be able to make sure that you're getting that confidant guide for your patient, in place. This is not something that, again, is always verbal. The ketchup on the shirt moment may be the eye rolls, the reactions, the stuff that you're doing right outside the room that they can hear on the inside. This is something that it could be any topic for that matter, but I think that you want to make sure that you're trying to open your doors up for the patient to be comfortable as best you can. And of course, if we don't do this well, then we're going to probably find that we're not going to get as much information to help the patient out. And then that may lead to many of the psychosocial and medical issues that we were talking about prior. So, again, be mindful of how you communicate and then react to concerns. It's important to think through. So the AOA and AMA have very, very bold statements that our professional organizations have come out with for affirmative policies towards the LGBT communities. The Joint Commission at this point has very affirmative statements. At this point, we have to kind of think about that what maybe was not there 20 years ago. Really, these professional bodies, the Joint Commission, really recognizes that we have to make sure we're providing care as physicians and healthcare providers to our patients in an optimal way. I'm going to try to go through each one of these points because I think they're important. So affirmative healthcare attitudes doesn't automatically assume that the patient's heterosexual. And I think that's probably one of the key features I'd ask about. And they adopt the belief that homophobia, not sexual orientation, is the problem. So homophobia and heterosexism would be the problem, not the patient's sexual orientation. They accept that the gay, lesbian, bisexual, transgender identity is a positive outcome for the patient. And they work with the patient to decrease internalized homophobia to help them achieve a positive identity, to again help them with a lot of those risk factors we identified before. That fifth point is something, again, we may not feel comfortable, when they've surveyed physicians today, 40% feel comfortable with this topic, and just in general, sexual history as a topic, 40% feel comfortable. So understanding the basic knowledge about human sexuality, there are actually there's some courses that are out there that you can seek out to really help you understand, especially the LGBT community more, so that way you can incorporate it and feel more comfortable with some basic questions that you can ask. And once people go through it, they then do some pre and post to see have they become more comfortable asking, and a lot of times they are. Our comfort is a part of it. So if I compare it to something like neurology, if a student says to me, gosh, I really don't feel comfortable with neurology, and you can tell because they don't know how to do basic skill sets, I tell them to take a neurology clerkship so that way they can really learn it better. If they avoid it, they're not going to understand it. It's going to stand out when people come in. So I think it's the same thing for really anything that we do. There are great mini fellowships, there are certificate courses, and in so many topics today. So I would encourage you, don't ever stop your training. This is an educational continuum that we're in. We should always be learning as we go forward. And then again, if things happen, whether they're covert or overt, we want to try to help each other out. So if you see a colleague, they may not even realize they got the ketchup on their shirt. You want to try to help people out. It's important today more than ever, because sometimes people don't have self-awareness, and sometimes they do, and they just need some more guidance as they go forward. So, the important part about what hopefully happens here is as we identify these risks, we can then start to do what we really do well with everyone who comes in, which is guide people through strategies, right? The plan, the nutrition, the exercise, safe sex practices. To get to that point, we've got to figure out a way to get a lot of that comfort and personal connection down. But this part, I know we definitely know how to help decrease obesity. We know how to help with safe sex practices. We just have to figure out a way to help the patient feel open to get the information. And then if we get these lifestyle aspects together, we're going to get into various types of other support groups. Keep in mind that if you've got and you'll hear Dr. Tartaglia speak about terminology, so you'll hear words like transgender, and then you'll hear transmasculine or transfeminine. So if you've got somebody who now is transfeminine, who in birth was male and now it feels as a gender identity female, they still typically have a prostate, okay? Almost always have a prostate. Therefore, we should be thinking about things like prostate screenings, right, as well. We need to know that, so that way we provide great care. We then have support group ideas for the patient because, again, anybody who's going through this, it could be even a family who has an intersex child who has genitalia that's not necessarily part of their birth gender. So you may have a male gender who now has female parts. They may need support groups to try to help out understanding what that means, to understand how they can help their family out, help the child out as well through that. So I think that these support groups are important. Being in this tri-state area, New York, Jersey, and Pennsylvania, be fortunate that we have a ton of support groups in this area. I don't want to name them all. Some of you work for them. Some of you actually know them in the area, but there's a number of really great support groups that are all within this region. In some of the rural aspects, they do not. So I think we're in a very, very good place. There's still not enough, though. So you can imagine that there are pediatric groups that really are having a tough time trying to understand how to really get support for certain populations. And I think that there's still not enough out there for support groups that exist. Looking at things like our intake forms, I think are important as well. So I think today with EMR, patient check-ins, certainly this is changing quite a bit. So for those of you who have an EMR, this may integrate a lot. The list may be a lot longer even, than you're seeing right now. But you can have these different categories for gender. This starts the conversation, at least to be able to then have with the patient, so you understand how they would declare as their identity. And again, this can go even further down the list, right? So each of these can continue as far as their relationship status, understanding, what they have. And again, I would think about those three questions I asked before, because this doesn't really give you those answers as to, are they sexually active with men, women, or both, and then how many partners in the last 12 months. But this may start the conversation as well to kind of get you to remember to ask about it. So the suggestions I would have are to start to learn this terminology and definitions. Again, you've gotten a chance to see that. And then asking the terminology that the patient prefers, which I think we're starting to see this more and more. So very, very common that we're seeing this right now. If I can ask just from the audience, how many on email use pronouns at this point? On emails, some may. I'm seeing this more and more for students are using it very, very commonly, medical students. So many of our patients, I'm seeing colleagues use it as well, pronouns, and we'll talk about what they are, but at least understanding and respecting and acknowledging how to introduce and ask about pronouns. Sometimes that you could have pins actually that will put your pronouns as well. I've seen that again, these are signs of support. So you may decide what you're comfortable with for signs of support. But I give you just some options as to what pronouns you might see. And these are things that are evolving, and I think they're going to continue to change. There are pronouns in here that you're probably going to look at and say, I haven't seen these before. Or maybe you've seen them, but you haven't seen them very often. And I think these are things that will continue to change. But understanding into the gender-neutral category, these pronouns are becoming more common as non-binary pronouns or terms. And I know that they may be, again, struggles as we have learned, a certain language, he and she, over the course of our lives. And I think that they had always been a plural type of thing. But now I think it's important to really think through that as this generation's coming in and really we're getting more comfortable with these terms, this is changing. And I think it's important that we also evolve. Dynamic is really the key that we want to keep thinking about. So you would want to think about, again, inclusive questions. I brought this up before. Sexual activity with men, women, or both. And then using gender-neutral language like partner or significant other. So that way they can expound on that. And again, we talked about this. Avoid making any assumptions, bringing in possibilities of bias, including identifying, for themselves or their partners. But what's important, and I guess not in COVID world with the handshake, I think the fist bump or the elbow or just simply apologizing is really key. We're all going to make mistakes. We're going to make mistakes. I think that, I have 4 children. I say my best day, I'm probably making a half a dozen mistakes in the house with the kids. I have 11 to 19 age group, so I'm making mistakes all day long. But I think that you want to make sure that you apologize because your goal is you want to learn. And I think that if we think of ourselves as the educational continuum learners, and that terms and things will change, and they should change over time, then if we learn from the patient, we're going to just learn and then we want to apologize. That's a good relationship, right? So if you're always going to be right, you're never going to learn, and you're probably going to find that that's going to be a problem because you're probably never always right, and you are never always right. But when you're wrong and you've offended, I think it's important to try to figure out a way to say, to apologize and then try to learn more about that issue from the patient. So again, when you're talking about sensitive topics, and this is probably one of the most sensitive that you may not be comfortable with yourself, approach sexual history with empathy. And again, we all have had training in it, we understand it, but sometimes because of our own discomfort, we're not open-minded and without rendering judgment. And that again takes practice, right? So in order for that to work, it's got to be practiced. And it's important that you try to practice that. So this is very key, that you take a sexual history for all of your patients. You could say it on an annual basis. I think we've probably done very well with that within our settings. I think when you get to that stage in your visit, that's probably how you decide to introduce it, that this is something that you do on an annual basis with patients. And I think that's something that's routine and part of your exam. It makes you and them more comfortable at the same time. Make sure that you're thinking about the STD risks, again, because there are a lot of things we can do today, that we couldn't do years ago. And again, PrEP is an example of one of those things that we can do today that we could not do years ago, as well as many different protective barrier devices or strategies that the patients really didn't know about years ago that we now know about today, as well as even consideration for unwanted pregnancies. These are things that we think about within the healthcare settings that really are going to help the patient out. And recommending safe sex strategies for prevention of that risk. And everything I'm talking about really is on the disease prevention side. But we have to really keep in mind when I mentioned that 10% of patients over the course of their time with you will bring up sexual issues, they're also going to bring up sexual functionality issues too. And I think it's important, as well as comfort I tend to see within healthcare, we're very comfortable with disease, chronic care, but we're not as comfortable with wellness. So you want to think about wellness and function. So if they're having any dysfunction or lack of pleasure or lack of sensation or lack of issues that really they feel are working, it's important to really think about function as well as dysfunction. And I think that's also for the history tips, something that you could really help the patient by picking up and asking them about questions about their sexual experiences. So part of what we do, it's not just how we are, it's what we do, within our environment. So providing a unisex bathroom for the patients, and depending on the size of your office, the systems obviously that we work in, the hospitals have done this. If you have a small office, it's important to really make sure that there's signage that's at least appropriate to share that there's a unisex bathroom. You can as well subscribe to LGBT magazines like The Advocate, or there's many others that are out there that have kind of evolved over time. I've kind of gone through a history of a couple of them that have been here years and years ago. Now there's a top 30 or 40 that are out there that people can have in their waiting rooms that at least are for the LGBT culture. And then displaying posters showing diverse and same-sex couples and LGBT or nonprofit HIV/AIDS organizations to really support the population that you serve. Very, very important too is, and we're seeing this, is non-discrimination statements. This is for really all peoples and our LGBTQ population as well, offering different brochures detailing risks and concerns, but really just having a statement that, just like we said, the Joint Commission, the AMA, the AOA, your state board expects that you're going to care for, regardless of sexual or gender identity, that you're going to provide fair, equal health care for all. And in conclusion today, think about this as, again, just this dynamic aspect of our learning. So we want to offer our patients a welcome and open medical practice that communicates safety and trust. And then that we understand as, again, the terms will continue to change. What I say to you today in 6 months or a year will probably change again. That's a guarantee. So it's constantly trying to get updated with the newest terminology and relevant terminology and concepts. And then offering your patients this proactive commitment towards diversity in their care so that way they feel comfortable and you can help them prevent disease as well as really have health promotion within their health care. And these are the goals that we talked about today, and I'll certainly answer any questions if anybody has. Thank you. Yes?
Coren, excellent lecture. Thank you so much.
Thank you.
My question is about when investigating sexual history, when's the best time or the best way to ask about specific high-risk sexual acts, such as receptive anal sex, for example? How do you kind of work with specifics like that?
Yeah, I think it's a great question. So I think the icebreakers start, like I mentioned before, is that you want to kind of gradually move into these more challenging areas that you will have to get into. But I think you want to start with that you ask every patient routinely these questions, right? That's your opener. Then you ask the 3 questions that we talked about. So those 3 questions are really your icebreakers, right? The 3 questions are you sexually active? Do you have sex with men, women, or both? How many sexual partners have you had in the last 12 months? So then the next part down is going to start to get into all those risk factor areas that I would start to really keep in mind that maybe you either going to ask outside of that or inside regarding have they had any STDs before in their history, right? So you want to really understand their background of have they had STDs. You can ask about the type of sexual practices that they have, and I think it's probably a good way to do it. And you could say, do you have oral, vaginal, or anal intercourse, and have you had that in the last 12 months, or let's say, just in general? I think it's important too because when you're starting to put them in the categorization for PrEP, if you look at PrEP itself, and I think again, for those who haven't seen the PrEP guidelines, they're very good guidelines with an algorithm that really get into what you just asked, which is who's your patient and what specifically is their yes or no of what they have done, because that's going to be PrEP yes or PrEP no And even the prep no still may yield the patient wants to have prep. But I think your point's well taken, that you want to start to kind of get into this, but you want to introduce it in a way where it's just gradual, into the visit. Just like if you have a pediatric patient, we don't go right for the ear, right? That's probably one of the last things that the pediatrician does. Or if they're going to get the shots, which is the shot the pediatrician usually gives last? Tanya, what do you give last? What's the most painful shot? MMR tends to, if you want to hear the cry go from here to here, you give the MMR, right? So I think that, you want to think about this from the comfort zone and, introducing these topics. I think it's good to start to kind of phase that in at that next layer. In those layers, too, don't forget about domestic violence. I think that's very important to ask those questions because that tends to be a screening aspect that gets missed. Don't forget about asking about all the other social history questions that, also may come with it, involving depression, which is more of a PHQ-2 or 9 scale, certainly the social history aspects of drug use. I think about this with drug use, too. Do you use drugs is not enough of a question. Am I right, Dr. German? I know my colleague, Dr. German, would say to me, that's not enough. We need a lot more than that. You want to really ask them a lot more, and you've got to think through, well, what are the types of questions and scales I can use? So I think that you're going to introduce it, but you want to try to phase that in. And I think that it's good to start to have some basic icebreaker questions. Here's a statement, here's my first 3 questions, and then start to get into STD background and then practices as well, function as well, okay? You want to keep in mind function. Your patients are probably, I find it's interesting, patients make appointments, and then if there's not a descriptive chief complaint, I know there's something they want to talk about, and usually if it's a person who's in my office and I really can't figure, more times than not, there's a sexual history component that they haven't actually disclosed to a front desk staff because they're really uncomfortable bringing it up, that I bring up in the office, and they're like, oh, thank you for bringing that up. They just appreciate the fact that we talk about it there. So I think these things are important. When they get that comfort zone with you, then they're going to start to feel more comfortable about talking about other issues that they may have that they really need some guidance and support for, that they just don't know what to do with. So, and you may not know what to do with them either, just to be clear. So I think that's where you have really good discussions, but hope that answers your question there. Dr. German. Yeah, Rich brings up 2 great points. One from the legality aspect. If you follow worldwide and even U.S. passport, now they finally have on the passports the ability to have X versus just M or F on there. The challenge for a patient is that they may or may not be able to go into many countries. There's 182 countries, something like that. But the minority of the countries right now would recognize that. So there's this challenge, just to your point, which is legal aspects of the US. Now you take it globally and think about that. And you're right, Rich, the training is something that, it goes beyond the physicians. It's your staff as well, and trying to think about it holistically for your environment. You know, you could be amazing at what you do, but if the team doesn't understand how to actually be interprofessional with care, it can hurt the patient. And domestic violence is one of those issues that is extremely underreported. It's a whole separate lecture that is important to think about. In this population, it exists. Thanks, Rich.